No, I tried like it for one, but that was like when you're.
I like it though, but I was saying, wasn't it like?
No, I haven't been doing it.
And I don't have to be in your clothes today. I mean, you did because you had to be in your stuff for your 302 lab. How did that go? Pretty good. Okay, now you guys have chosen your spots. Are you comfortable with where you are? Because weirdly, you'll end up sitting in the exact same spots as the rest of your time with us.
What's going on, baby?
No, you can change now. Because it really unnerves us when you switch like, middle of things.
Which one?
I know.
What's that shaking today?
For shape. Okay, generally I take attendance with a QR code. Usually get to send your name and a fun little question on there. Sometimes it's silly. Sometimes I really do want to know how you're doing. I'm the only one who looks at them. If I share any of that information, it is completely anonymous. So today's question is, what is something that has made you happy, sad, excited, worried, anything about the first week? So if I bring anything up, it would be somebody mentioned they're really happy that they got their accommodations taken care of because I got internal letters, which is awesome. Or they loved going to lab or that kind of thing. It would never be Billy Joe said that they loved that their accommodations were taken care of because that would be a FERPA violation. We don't do that around here. Okay. As you know, I start the day with something nice to concentrate on. So today's is live with intention, walk to the edge, listen hard, practice wellness, play with abandon, laugh, choose with no regret, continue to learn, appreciate your friends, do what you love, live as if this is all there is. Love that. So here we go. That's what we're doing. All right. You guys know me, the puppies. That very tall child there in the middle, he is my son. He's 6'6". I don't really know. I mean, my husband's only 6 foot tall. I don't know what happened. He lives in Denver with his fiance. She's amazing. I will definitely keep her. She keeps him in line. My daughter Bryn works for Versus Health as a mental health tech. Justin's going to school at Metro State after spending 6 years in the Air Force. He came away from that with a seizure disorder that he did not have before he went in, so he is medically retired. And he's working on his degree in technical writing. My husband is a paramedic. He has been for 30+ years. He worked in Evergreen. So he commutes north from Colorado Springs. I commute south. So on any given day, we're leaving the house around the same time. We are originally from Las Cruces, New Mexico. We've been here about 26 years, and I still have a heart for New Mexico chili. So don't hate me when I still say that New Mexico chili is better than Grew up right around Hatch. I'm sorry. Las Cruces. Sorry, I love Hatch chili. My dad came up from Albuquerque last week and brought me chili. Hand delivered. Okay, tips for success for this class. Participate whenever possible. I don't like to hear myself talk all that much. It's just kind of weird. Utilize all your resources. There are tons. We went over a lot of them on Tuesday. I got some emails saying that they were having trouble seeing some things in Elsevier. So at breaks or after class, let's be sure to connect so I can make sure that you have all of those connected and know where you're supposed to go. Please take notes, be engaged, ask questions, seek clarification. I just read literally this morning an amazing article on what happens when you engage your brain by writing, when you take notes instead of typing. This whole international study that was done on writing instead of typing. So if you find that you are struggling to retain information, switch. You can have your computer there, you can have your information there, but switch, start writing your notes out. You want to record every lecture, post it afterwards. So if you're afraid of missing information because you write too slow, that's not a problem. Don't worry about it. You can go back and listen again. Don't forget, there's no dumb, silly questions. You start a question with me that says, I have a dumb question. Absolutely not. Rephrase your question, start again. If you have a question, somebody else in the class probably has the same one. Also, we don't talk about ourselves that way. We're not dumb. You're not silly. You're not willing to ask me a question. You won't be willing to ask the provider a question later on. You're taking clarifications. Right? Why it's important to value your questions. Okay, we're gonna go over the syllabus and topical outline, and then we'll dig into stuff. So unfortunately, y'all only get me for 6 weeks in this class. Sorry. I had to put my foot down somewhere, so I get some sort of break. Otherwise, I would teach like 12 months of the year. So much as I love teaching, I'm only doing 6 weeks. I don't know who's going to do the second 6 weeks. But I trust that they're going to be just fabulous because anybody that Dr. Person sits in here is. Summer, as you guys have heard, is a little bit less casual, or a little bit more casual rather, when it comes to our office hours. So before or after class on Mondays when we're here, do not come to class on Monday. It's a holiday. Nobody's going to be here. Campus is going to be locked up tight, right? I'm also on campus with you guys all day on Tuesday. If you need some time, pull me aside on Tuesday. We can chat during lab. And then Wednesdays, I'm here teaching global health. I'm here 8 to noon. So if you need to meet before or after that, send me an email and we can schedule some time. Friday, Thursdays and Fridays, I have an open schedule. You can schedule that on Calendly. We can do a Teams meeting. This class is face-to-face. If there's ever a change because of life happening, those announcements will be placed in Blackboard, so make sure that you're paying attention. It took me nearly a full semester to realize that if I click a little button, it actually sends that announcement out as an email to you guys. Because I was used to working with Canvas, and Canvas does that automatically. FYI, we're going to Canvas in January. Woof, woof. Excited. Okay. Weird things teachers get excited about. So I do really try hard to remember to click the announcement button. That'll send you an email as well. So make sure that you're checking Blackboard and your email for announcements. We utilize the nursing process in meeting primary healthcare needs of individuals, basic nursing interventions. This is where we're really going to start thinking critically and applying therapeutic communication as we begin to really put some hands on patients. I want you guys to keep some things in mind though. You've met Professor Nichols. Have you had class with her yet? Yes. Okay. And you've met Professor Rafi Bayless. Had class with her. You've met Professor Ginny Bays at Farm, and you've had me. While they are 4 separate courses, they all intertwine together. Okay? So instead of thinking that you're studying for one individual thing at a time, think about how they interact with each other. Say you're going to give a medication, you learn about that medication in pharmacology, you're studying really hard, learning about beta blockers that you give for a patient who needs to bring their heart rate down or bring their blood pressure down, okay? And studying that. Well, in order to give that medication, you need to understand from concepts class your scope of practice as a nurse. In order to understand that, you need to have studied some from concepts. You need to do an assessment on the patient's cardiac things that are going on, right? You learn vital signs and all of that from health assessment. And then you need to understand your 6 rights of medication administration that you learn in fundamentals. So you actually need a piece of every single course that you're taking to wrap that all up and be able to give that medication. So instead of thinking about them as individual classes, I really have to study this. As you go through and study, think about it as holistically as possible. Don't try to segment them out and silo each course. It's really going to help. Our course objectives, to see these student learning outcomes, this is the stuff that we are working on throughout the class. Multicultural caring through patient-centered care, collaboration within nursing and interprofessional teams, demonstrate the beginning of nursing judgment. We're going to employ principles of safety and quality improvement as we monitor outcomes of care processes, minimize risk to patients and providers. We're going to look at different information and technology and how they aid in communication. We'll identify beginning behaviors of professional identity, integrity, and leadership. Identify knowledge of administration practices and guidelines of selected medications. And then we'll discuss how the American Nurses Association's scope and standard of practice and code of ethics are incorporated in extended care settings. This is a 3-credit course, expected to do about 7 hours of coursework outside of class. There's lots of different ways that we go about learning in this course, between guided discussion, group work, application of learning to case studies. There's e-learning on Blackboard, passport quizzes, interactive online quizzes, reflective thinking, we'll go through some case studies, and then exams. These student learning outcomes are ones that you will see throughout every course. They're the same, and these are end of program outcomes. Our required texts and other materials. So Potter and Perry, 11th edition, is our text that we use. And then there is the Silvestri Comprehensive Review for the NCLEX exam. Love that book. Do not purchase anything below this green line. That all comes as part of your course or your student fees. So exam soft, which you should already be plugged in and ready to go with that one. Have you tried your practice exam yet? Living Pod, which is PassPoint, and then Unbound Medicine. Don't know if that's gotten out to you guys yet. The American Nurses Association Code of Ethics, and then 7th edition APA manual. Course requirements, basic computer skills are class. We do advise Firefox or Google Chrome as the best browsers for Blackboard. Email communication, please let me know who you are and which class you're in, especially as we're getting to know names, so I can figure out how to help you. Especially if you're seeking care or seeking assistance with another course, so that I can figure out which direction I need to give you some guidance on. For homework, we have quizzing and online assignments, as well as the Colorado Rural Workforce assignments. And there is information on how to access those. They are not open to be able to do right now, so don't try to do them right now. There are unit exams. 4 unit exams worth 80% of the final grade. Every course that has a lab associated with it is required to have your unit exams be a minimum of 80% of the grade. So that is our standard here, at least 80%. All exams need to be taken at the scheduled time. If you're absent for an unavoidable circumstance, please notify me as soon as possible. If you have ADA accommodations, please schedule them with the testing. Please schedule your test with the testing center as soon as possible and as close to the testing date as possible, testing day and time. You have 5 minutes to review the questions that you got wrong afterwards. There is no picture taking or videotaping allowed during the exam or the exam review. And then when you come in for your exam, you'll put all of your stuff up front. The only thing that should be at your desk is your computer. If there is math questions, you'll be allowed to have a writing utensil and a piece of paper. There's a calculator built into ExamSoft, so that's available to you there. All right. If you receive a grade below 80% on an exam, meet with your instructor. That goes for any course you're taking. And then if it's below 80 on 2 or more exams, please schedule an appointment with me since I'm doing retention. Class attendance is expected. It over and over and over again, it demonstrates when students attend class regularly, they do better in class. Surprise, surprise. So please be here and participate. Each period is each class time is 1/12 of the grade. We have 12 classes. In order to obtain a satisfactory grade, it's 80%, so you need to attend 9.6 classes in 12 weeks. That's easily done. If you have a rough day, if car trouble, end up waking up with stomach pain, not a problem. Let me know. End up going to the hospital and have a written excuse, then that's an excused assignments or excused absence. There is a comprehensive pass point mastery at the end, where it's 5% of your final grade. No extra credit is ever given in any of the nursing courses, so please keep that in mind. There's lots and lots of extra stuff added to each module, whether it's videos, podcasts, different recordings. The PowerPoints are just the ones that are associated with that module, but there's links out to other resources so that we meet people with different types of learning styles. We want to make sure that we're accommodating all of those. I do recommend that you review those prior to class because they can help with understanding that information. There's that AI statement again. So you're welcome to use AI. However, it's for very specific things. Brainstorming, refining your ideas, fine-tuning your research question, checking grammar and style. But it cannot impersonate you in classroom context. It cannot complete your group work. It cannot write a draft or your final writing assignment. It cannot write entire sentences. And then if you have any questions, you do need to make sure that you cite it. And if you have any questions regarding how to do that or other APA help, there's a wonderful writing center in the park. Here is what makes up your grade for 232. So we have 5% comprehensive pass point mastery, 5% attendance. The quizzing, so that's pass point, the Colorado World Health, and any other quizzes that come up is 10%, and then 4 unit exams at 20% each. It's 80% for a total of 100%. And 80% is a minimum passing grade overall. And any final course grades that are between 89.5 and above will be rounded up to an A. It's the only time that we round. You make sure that you follow all policies within the university code of conduct as well as nursing student handbook. Instability or lack of conformity will not be tolerated. There will be nursing tutors available. So as soon as they're in Starfish, I'll make sure to post their availability. Some of you guys have already connected with them. So if you would like to connect with them before their Starfish is available, send me an email and I can connect you guys via email. Accommodations, if you have a documented disability, please reach out to accommodations. They are more than happy to work with you to get that squared away. You see a Starfish notification regarding your academic success. Please make sure you read that. And then if there's any academic misconduct, that will be handled through the instructor, director of student conduct, community standards, the instructor, person's gets involved. And then our civil rights and compliance statement. Any questions about the syllabus? Right, and then our topical outline, I tried to make sure that it was color coded because that's how my brain works. Hopefully that will work for you guys too. Anything that's in orange is the stuff that comes from the Silvestri book. Anything that's blue is our Potter and Perry book. For the love of all things holy, please read chapter 4 from Silvestri before you take your exam next Wednesday. It is all about test taking strategies. Nursing test questions are different than any other test questions you've ever taken in your entire life. We hold up 2 oranges and we say, which one is the most orange? Then we ask something like, why? And then you go, why did I come to nursing school? There's another one that's a picture of a dog that has his booty on a chair. His front legs are standing. And it says, is this dog sitting, standing, or laying? Valid question. Right? So reading through chapter 4 will help you start to get into the mindset of how you answer those questions. It's not just regurgitating information. You can't just sit there and memorize all this information. It's not like memorizing all the muscles in the face and then putting pins on them in anatomy lab. It's great. We all had to do it, right? Every last one of us passed anatomy lab. It's different. So read Silvestri chapter 4 before your first exam. Other stuff, that has to take priority. Okay? Depending on, I have not posted the nutrition. Well, I think I posted a small nutrition lecture, like a 7-minute recording, I think, for next week, because we have like a chill next week. Depending on how long my lecture ends up being for week 3, I may add in some other touch points for nutrition. We'll see. I haven't done that lecture yet. That's for week 3, other problem. I haven't gotten there yet. So, and then anything that's under that last column for purple is assignments when they're due. They do correlate to when they're due in Blackboard. So keep a close eye on when they're due. Any task point though is absolutely due right before your exam. So in the case of the next time we have a Friday class, so Friday the 5th, those pass points are due Friday by 1 p.m. The whole point of pass point is to use them before you, as study guides. Yes. Also here. No, pass point is Lippincott. Pass point, course point, Lippincott. If you don't have access to it yet, It's because you haven't gotten the email yet, and that's because Lynette doesn't have the course code yet, even though I created it. You guys get that email yet? Okay. So Lynette's still waiting. She didn't have it on Wednesday when I talked to her.
We did pick up our numbers.
Yes, okay, we're making progress. And I saw you got the exam sauce. Making progress. We'll get there. And there's only 2 of the pass points. And I think they're like 20 questions. So it's not gonna be super tough. So, but then like the next one, because we have a 9:30 exam. They're due at 9:30 in the morning on the day of the exam. You have to pay attention. Not trying to trick you, just keeping you on your toes. Yes.
So is Casper like kind of like a different exam software just used for quizzes?
CastPoint is well, because you can go in and create your own quizzes on there and take your own quizzes so you can use it as a platform for exam prep. So we go in, we put quizzes in there, and those quizzes are worth points for part of your grade, the ones that we create. They're one time only. So I would kind of suggest you save them for the last little bit of your study, but do them before so you don't get counted off. But then you can create ones before based on content and practice with those questions as part of exam prep. So once you get into there, we can go for it.
So if we didn't get the email for PassPoint, you can't get into it?
Correct. Because Lynette has to set up the actual larger course, even though I've set up my portion of it. I have like the code that's already listed in the class. She still has to create the class has to be created for her by LiveMePod. Then she has to put all y'all's names in it. And then,
So do we maybe know when we get that?
I'll text her at break and ask her if she's heard. Because the last time when I talked to her on Wednesday, she got a code for University of Washington, which is clearly not us. Not even the same area. So, yeah. So hopefully, I don't think that's happened before, but hopefully we'll get to it. Yes.
Where do we find the culture box? Oh, is that our
The which one?
cultural box?
Yes, so, okay, so y'all know the really horrible thing that I did, when you go into modules under Blackboard, anything that has page numbers listed is from the wrong version. Because I went and spent all this time before I realized I had the wrong version, and there's still, Elsevier is still waiting to give me the right version. So it is around there. I did put the title of the box that you're supposed to be reading. So it's like whatever the title's. So you know which one to look for. So really bad. I will update those as soon as I get access to the correct edition. So so if you're going, as you're going through the chapter, they'll either be like headings of a section. So the one I think of off the top of my head is like sleep apnea, and then it's like 3 paragraphs of information on what sleep apnea does to a patient. And then later on, there's like a cultural box, blah, 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 47.6. And then there's something else within that. It's titled something else. And then that information within that box. So all of that should be the same, just on the wrong page. I spent so much time. I was so proud of myself. Like, look at all this good information I'm giving them. And only to find out that yeah, you know, the road to a certain place is paved with good intentions. So that's what I felt like. So maybe if I get access this weekend, I will be spending my Memorial Day holiday doing that. But yeah. So I will try to make that better and easier for you guys. Okay, any other questions?
Question.
Yes.
I was looking up the study tips.
Yes.
It says, review the study guide, where do you get this study guide?
When I post it in the modules.
Okay. To make sure it's an overlooking it.
Now, I usually will, I haven't made the exam yet, and when I make the exam is when I make the study guide. I am not a fan of gatekeeping information. I think that's not fair to you, it's not fair to me when I go, wow, did I even teach that? And so when I make an exam, it'll be, how can you tell, based on a skin assessment that your patient is, struggling to breathe? And then I would go in my, exam review, make sure to review signs and symptoms of respiratory problems that you can see in your skin assessment. So I'm not giving you the question, giving you the content of the question, if that makes sense. So that's how I need to make the exam and then. Because it's my gatekeeper. Other questions? We ready to dig into some content? Okay. If you missed the attendance, I put it up a couple times just in case you missed it or couldn't get logged in the first time. Question for you guys. What will you do as a nurse? What kind of things are you gonna do as a nurse? What are you gonna do? Care for sick people?
Yeah.
Okay. Hey, okay. Care sounds. Okay, what else are you gonna do? Ask questions, I like that. What else? Okay. Stay professional.
Make good observation.
What's that?
Good observations.
Good observations. What else? Advocate. Oh, some good words today. What else? Yes. Sorry, I didn't hear. You're good. I'm speaking quietly. Communicate. Communicate. What kind of communication? What's the word we like right before that? Therapeutic. Oh, that's our favorite, right? Therapeutic communication, which means I'm not going to stand there. So, tell me why you're here today, right? I need to tell you a story about that. Yes. For the patient's family, yeah, regardless of how old that patient is, right? Do you know what I didn't hear from you guys? And I really, really love that I didn't hear. I didn't hear, I'm gonna start an IV, I'm gonna put a Foley in, I'm gonna give medications. You do that though, right? But those are not the first things that you guys thought of. Are those the things that we see on TV though? I'm gonna crack a chest. I'm gonna give really big, strong, crazy medications. I'm gonna do a C-section in the middle of the ER on a patient who's dying, and hopefully we save this baby and the mom, right? None of you guys were like, I'm gonna start an IV. I'm super excited, right? Do you know that we refer to nursing as the art and science of nursing? For these very reasons. All of these things that you guys just mentioned is absolutely falls on the art aspect of nursing. Science, this is where we get the evidence-based practice. Why do we start the IV? Why do we give them medication? Why does our patient need to have that CT scan? Right? I loved that I didn't hear those. So when we think about nursing, we absolutely have a collection of specific skills, right? We're gonna go through them in health assessment, we're gonna go through them in fundamentals lab, you're gonna get to go out in the clinical setting and be able to do that. But ultimately, in spite of recent federal guidelines, nursing is a profession. Nursing is something that we do, something we are, something you're becoming, ways that we make a difference, ways that we change lives. People may never remember your name, they remember how you made them feel. I think my answer said that. Need to put that on here. To me, this was not my style. I'll do that. Okay. So as a profession, we recognize that it requires basic liberal foundation and extended education. We know that you guys have taken a lot of time to get either other education and you're like, hey, I got this bachelor's degree, burning a hole in my pocket, I'm gonna come on in and do nursing. Or you were like, I have nothing better to do. That's how I became the DNP. So I guess COVID, I don't know what else to do with my life. Theoretical body of knowledge, we have defined skills, ability, and norms. That's where our nursing standards come in. Our Board of Nursing helps define that. We provide a specific service. We do have that aspect of nursing. We have that expectation that when we go in and we're working as a nurse, we do these things. It's basic understanding. The wonderful aspects is we have autonomy in decision-making and practice, which means physician gives you an order and you go, oh, yowza, that could kill my patient. Absolutely not. That is autonomy. But so does your patient, which is where that code of ethics comes in. Sir, I have blood pressure medication. Yeah, no, I'm not going to take that. Last time I took that, it gave me a cough, and I don't want to take that. We educate, we inform. I don't want to do that. All right, I'm going to document that. I'm going to let the provider know. Because I have an ethical responsibility to my patient. We have all of these different things that we do as nurses that make our job more than just me walking in. I'm a trained robot. I can do all these things, right? Start to see how it's a little bit complicated. So it's brought up professional. In order for us to act professionally, we have to use critical thinking skills. So that's more than just me walking in and saying, that medication can kill my patient. I guess I'll give it anyways. I mean, the doctor said I should do it. The PA said I should do it. They're bigger than me, they're better than me, I guess I'll give it. No, absolutely not. We administer quality patient-centered care, which means we have to have that patient a part of that decision-making process. We do not just walk in and treat that patient as if they're a mannequin and we're just doing the work on them. That's not fair to them, and it's not fair to us. They also have to be responsible and accountable. The old adage, it's not charted, it's not done. Responsible and accountable, right there. We have to be able to understand the scope of professional nursing practice. It doesn't change a ton from state to state. There are some states that are a little more liberal than others. Where we see it probably the most is with our licensed practical nurses or licensed vocational nurses. Those change a little bit more drastically from state to state. But we do need to understand what can you do as a registered nurse? What can't you do? Well, I can 1000% tell you, I cannot intubate a patient. My husband, who has less training than me, can intubate all day long. I would want him to intubate. I do not want to catch that with a 10-foot pole. My respiratory therapist that I work alongside with in the ER, please, by all means, I will hand you the things that you need and intubate away, my friend. That's knowing your place and supporting the people that you work with. We advocate. I love that. We advocate for patients. Not only do we advocate for patients, we advocate for ourselves, our fellow nurses, which is really quite big right now. Had some pretty devastating happenings around the country. We've had the past 2 weeks, there was a nurse, I believe she was in Texas. Patient was declined medication, denied pain medication in the ER. We left very, very angry. Waited for the nurse outside till she got off work, beat her with the life, parking lot, another nurse, see. There was another very angry psychiatric patient who had gone in to be seen and then left AMA and was just wandering around the parking lot, didn't really have any affiliation with her, and shot her and she died. And those happened in the past 2 weeks. So there's some really big safety concerns that advocacy is becoming more and more front and center and necessary. The Robert Wood Johnson Foundation, the Future of Nursing Campaign for Action, that's a huge push. If any of you guys have watched The Pit, old like me, Noah Wiley, in love with him when I was young, still in love with him. His mom is a nurse, 50 years, and he was on Capitol Hill this week advocating for nurses and safe ratios as well as safe with me. So one of my big things is healthcare should never be for profit, and this all ties in together. So that's where that all comes from. Back to the art and science of nursing. So we have to have that basic scientific understanding of what's happening within the human body. Really can't go and take care of patients and be one step ahead of the shenanigans that they're going to cause without that basic scientific understanding. And we loop that together with critical thinking and clinical judgment to, it's always my goal, one step ahead of whatever they're going to do. If blood pressure's stable right now, what are they going to do in 5 minutes? So we also need to stay on top of what is our current knowledge. What do we know about certain medications? What do we know about practice standards? Is there new guidelines for women's health or pediatric asthma? What do we need to stay on top of? What is our specialty? That insightful and compassionate approach that guides us with our therapeutic communication has to be there, or we are just people moving in and out of a room, just doing things. And I think that everybody's had that experience with a provider. Hi, how are you today? Why are you here? That completely impersonal approach where they're just like locked behind a computer and they don't have anything there's no connection you have with that person. And in a world where so much is driven by technology, we are starved for that feeling of connection. Now, we love better stages of nursing proficiency. We actually use it as part of the nursing program. theories are something that is just near and dear to nursing. Right now, you guys are novice. You're just hanging out in that end stage, brand spanking new to these things, hearing things for the first time. You could be, excuse me, an advanced beginner if you have more experience, the young core, CNA, advanced care partner. But you're really just getting your feet wet. And then as you become more and more, as you learn more as a student, you are excelling through better stages. By the time you graduate, you should be between competent and proficient as a student. But guess what? Graduate, and as a brand new RN, go all the way back to novice again. Oh, it's hard. You cry a little bit, you're sad, and it's hard, but you are working your way back up. Then you say, oh, man, I don't want to work med surg anymore. I'm gonna go try a new thing. You slide all the way back down to novice again. And so it's this wonderful full circle every time we do something. I think I've done it like 4 times. I'm kind of over it. But I love the fact that we are constantly learning. Went from feeling very, very comfortable working in the ER. Like, I got this. Anything that rolls in that door, if I don't know what to do with it, I know who to ask. And then I was like, I'm going to go to outpatient surgery. It can't be that hard. Yeah, it was not what I thought it was going to be. And I went to my husband and said, I'm going to go back to the ER because this is not. And then I loved it and got to where I was very, very comfortable with it. Gave the person that they came to because I knew the things. Then I went into education and I don't know anything. Now I've been here long enough that I love it. So we just keep going round and round and it's beautiful. Okay, so who determines the definition of nursing? Well, the American Nurses Association, one of the guiding lights of advocacy for nurses, about nurses, says that nursing is the protection, promotion, and optimization of health and abilities. We work on prevention of illness and injury, alleviation of suffering through diagnosis and treatment of human response, and then advocacy in the care of individuals, families, communities, and populations. They also set up the scope and standards of practice, standards of professional nursing practice, and standards of professional performance, as well as attendance. There's also a similar version with the International Council of Nurses. This encompasses autonomous and collaborative care of individuals of all ages, families, groups, and communities, sick or well, promotion of health, prevention of illness, and care of ill, disabled, and dying people, and then advocacy, promotion of safe environment, research participation in shaping health policy, in patient and health systems management and education. And that's the International Council of Nurses. Also a huge advocacy. Yes.
I had a funny story of something to back up the advocating for the profession of nursing. And it might not have been I do our charge nurse in the IMC a couple of years ago, and this patient treating a nurse really bad. She brought in the sign, this giant sign, like, I don't know, 6 foot tall, and said, you can treat our nurses right, or you can get out. She might not have done the right thing. She's not the charge nurse anymore or manager of that floor, but it was pretty bold, and people are going to stick up for you. I've had people say, you're not going to be the CNA in that room. You want to think you're not treating you right. There was, hey, we are here to take care of you. Like, I need you to treat your CNA right, whoever it is.
Well, we're seeing more and more that there are signs like we will not tolerate, and it's like a whole litany. You see how it has them all over the place. I have yet to see people physically removed for such behavior. That would be very nice.
I haven't seen that.
Yeah,
Yeah, I was working in the yard and forced me to remove there. To that, like, granted, then people have to be to that.
Yeah.
Or out of it, whatever.
I love hearing that, because a lot of times you hear the stories of, well, what could you have done different?
Well, and sometimes when they start acting up, there would be a change in medication in there.
Yes, we absolutely talk about that, because that is,
So you just get.
are we not refusing the break? So, let's take a 10-minute break, and then we'll start on some historical highlights. So be back at 5 after. Yes. No, that's fine. I am somebody.
I thought you said one.
Yeah. What is G to MCG?
No classes on Thursday. So NCG.
Yeah, because I'm bigger. So it'd be, and so G and
Similar, but the.
that's for.
MC. Okay, that's right, okay, there we go, but if I want to do a grant to, directly to an MC, that's.
1,000 times the microgram. It's almost like-
On. Yes.
Turns on the lights, you know, you can see the projector. The lights, the projector,
Oh,
you can turn it down.
let me see, I know that turns them all off.
But, and then I'm not.
It's all or nothing.
Yeah, nothing.
I do nothing, you guys will fall asleep, it's been a long day. Oh, God, no.
Right, and then like, remember.
Yeah, exactly. I don't like. He's not complaining about me.
Somebody. It says 100% households chloride or 10 milliliters over 5 minutes IV. 1 liter would be injected. Yeah, it's in those years. So the two. So that's how you just think about it. There's no math.
I mean, that's the.
There's no like, there's no
I
way.
gotta get to the university.
Is already no reason, so you don't have to change the million tonight, so it's for.
Gatorade would be with. there's a lot of games. So like, 10. Bottom becomes one. One of them. But if you do like shit, like 1 gram, 1,000 milligrams, 1,000 milligrams. Yeah. Don't overthink it.
We're gonna probably down to do.
I like to write down with like what I think the numbers. I like mentions.
That's why I didn't.
Yes, I like that. Where is
I suppose. And it's a lot.
Oh, no, that's not.
That's not.
No, it's not.
So.
I don't know how I've been using it for so long, but
No, I'm just, I can do that. I think I'm saying, I want her to learn this, like, basic automation. So it's like, it's. I know, just be like, it's. Like that. Or Q squared, Q plus Q squared. Especially for the thing you were doing. Right, it's been very, but every year it's been out, though, I would like have to. Fun, like, I get it, and I start doing it, I get it back to where I messed myself. I just have to go back here. It's not, I don't have color, so it's not. Yeah, but this is what's presenting on Thursdays, and they decide to go different numbers, because I don't know which one to take back.
Did you see 29?
It's all right.
It's like, it's like coverage.
It says there's a hundred because I mean, every 5 million, that means that's a big. Like, so then what the hell is this? So I don't know.
I had to be really.
Yeah.
And then you have to see there's a. I know. There's no sense to this. There's no way. Sometimes I say.
I was seeing that one.
Okay. I actually not. Guys, when you see associated email now or very soon, if you have not already, she got it moments before I texted her. It's been a whole fiasco. So hopefully that is there.
Wait, what?
The past point email, Lynette said she has sent it out.
He asked them for.
She has sent it, she is sent it, has sent it or is in the process of sending it. You will get it today.
Her name is Lynette Lover.
So it's coming, I don't know if it's, who's it coming from? Lynette's. That's why I said, you gotta pick your place. Cause now you're set there. Now you have the right to.
No one else here.
Okay. So historical highlights. Y'all are gonna find out, I'm not a fan of Florence Nightingale, okay? She actually was not the nicest person. She did tell us that we need to wash our hands. Yay, thank you. But she was a racist, guys, okay? And she has become like our favorite knight in shining armor nurse, and there's other people who have done amazing things. Eliza Mahoney, first African-American nurse in the United States, amazing. We have Dorothea Dix, Claire Barton, she's responsible for the American Red Cross. Lillian Wall and Mary Brewster, thank goodness for that. We have the Henry Street settlement. We will talk lots more about these fabulous nurses in global health. Love that. Florence, Bernie Moore, Claire Barton, these gals, and Dorothea Dix. Dorothea Dix organized hospitals. She was one who said, you know what, maybe we need to be a little more organized instead of just cramming everything into one spot. Oh, not Eliza Mahoney, sorry, Mary Mahoney. And she also was the first to graduate from an American nursing school where other African-American nurses had not been formally trained. So. All right, so nursing as a profession, we need to administer quality patient-centered care, practice in a safe, conscientious, and knowledgeable manner. And we are responsible and accountable not only to ourselves, but our patients, their families, as well as our peers. So we have quite a big role as a nurse. We have to be an expert. We have to know how to modify the care depending on what's going on with our patient. Pay attention to treatment that may be impacted by the patient's unique needs, culture, spirituality, their family dynamics, and their personality. You know, you walk into a room and you have a sweet little lady in there versus an angry 25-year-old gentleman. They're going to have very different care needs, right? And we have to change on the fly, going from one room to the other. That is a big job. So we no longer use the term nursing diagnosis. We have changed that to nursing priorities. So putting that into critical thinking practice, it's no longer diagnosis. Leave that for the providers. We use nursing priorities. And those priorities are based off of their medical diagnosis. Now, for our nursing education, every registered nurse takes the NCLEX. So if you graduate from an associate's degree program or a bachelor's degree program, you take the same NCLEX. Doesn't matter. When it comes to continuing education and in-service, that depends on where you live and where you work. Colorado, we do not require continuing education to renew your license. They're one of the few states just says, pay us money, no CEUs. They expect the place that you work to be requiring your cities. Yes, when I heard that, I was like, excuse me, what? Yes, other states require as little as none, and as many as 120, and some have very specific guidelines. I was licensed in Nevada for a while. They actually have a bioterrorism, 2 hours of bioterrorism and 4 hours of sex trafficking CEs that were required. In addition to the ones they required. So it depends on where you're living, working, and where you're licensed. So. Now, when we look at our responsibilities and roles, you wear a number of different hats. I love this picture, the fact that they have all these arms. If we had arms like this, we could be unstoppable. Imagine. First of all, autonomy and accountability. Yes, we've talked about this over and over again, right? Well, number one, we're a caregiver. Many of us, and I joke with it, the first day of lab, like I could ask you, why do you want to be a nurse? Well, I want to care for people. We all probably have that somewhere in our backstory of why we became a nurse, why we want to become a nurse. But truly, at the heart of it, you have to have that ideal of, I want to care for people. Otherwise, it's not a fun job. It's hard work. So having that idea in the back of your head, I want to care for people and connect with them, that is a huge aspect of the job. I want to advocate for people. I want to be the voice when somebody doesn't have a voice. You're going to be surprised at the amount of education that you provide to patients. Something as simple as, yes, you can give a sick child Tylenol and ibuprofen at the same time to bring down a fever. We want you to. And then you alternate them to, please tell me if you start to have a rash with this medication, right? Or you start to have trouble breathing, I need to know that. How to communicate properly. You may think you communicate well. It's hard. And we learn every single time we have a bad interaction with somebody. You learn that maybe that wasn't the best way to do it. When I first started working in the ER, I am not a small person. I recognize that. I love to know what doctors tell the patients, because inevitably what the patient hears and what the doctors told them can be either a little bit different or very different. So whenever I saw a doctor go into my rooms, I would sneak in behind them. Sometimes I had to clean up the mess, whatever the doctor said. So I would just sneak in, and I would just stand there, kind of up against the wall in the corner, thinking that I was being all sneaky and quiet, right? So I'm standing there and I snuck in. One of my favorite techs in the whole world, her name's Brenda. Even to this day, she's pushing 50. She looks like she's the nanny to her 5 children. She's starting an IV on the patient. And she looks up at me. I'm standing there like this, thinking I'm being all sneaky. She looks at me, make eye contact, and her face kind of gives me like a weird look. She like kind of nods at me. I'm like, I don't know what you're trying to say. She's like, I'm thinking, what is happening? So she finishes getting the IV, gets blood, finishes up what she's doing. The doctor leaves. I introduce myself, go about the time. We walk out the door and she goes, what has you so mad? And I'm like, what are you talking about? I was just standing there. And she's like, you cannot stand like that. No, don't ever do that again. She goes, I know you, but I thought you were really bad. And I was just, just standing there leaning up against the wall, just listening. And she was like, no, you looked so angry. And it was one of the first times, even though I had been told over and over and over again, watch how you position yourself, watch how you stand, watch what you're doing. Well, apparently, you stand like this and don't do anything with my face, resting, whatever. I look mad. So if you catch me doing that, it's because I'm not consciously, not because I'm mad. And so I try really, really hard to find other things to do with my body parts, because it's awkward and now I don't know what to do. Yeah, so now it's like, okay, well, hold on. Let me look casual here, right? Because we have to pay attention to how we're presenting ourselves. How do we give that same information to the patient and not have them go, hey, what's going on there, right? But we also, our management of the patient, the energy in the room, you walk in and you're like, what did I just walk in on? There's something funky going on, right? Management of medications and time management. Like manager takes up a whole lot of information right there, right? And then career development. How many of you guys want to go on and do something more than be BSN, RN, and work on the floor? Lots of people have goals well beyond this, right? It doesn't matter what it is. It could be something, I'm going to go on and become an educator. I'm going to go on and become an NP. It doesn't matter. Career development, you should never stop engaging in the education process. We have a dynamic nursing care model. If you see a nursing care model that does not have patient and family in the middle of it, throw it out. The patient and family needs to be the one that's what we're there for. We are caring for that person. That's how you have a holistic model of patients. If the patient and family is not in the center of that, how are we doing patient-centered care, right? The healthcare team surrounds that, and the healthcare team includes anybody that is in contact with that patient. That is your CNA. That is your, heck, for the most part, even during COVID, environmental services was a huge part of that healthcare team. Dietary. Anybody that comes in contact with that patient becomes part of that healthcare team. How are we getting that patient from sick to well? How are we getting them back to whole, to the place they were before? And then within that community that surrounds them, how are we improving the health and well-being of that community? Nurses have a responsibility to act as advocates for their community as well. They were heroes during COVID, they were part of that. They're a visible part of that. And all of these arrows represent the many different ways that nurses are involved in that. Teamwork, innovation, respect, integrity, compassion. All of these different things that nurses bring to the table. And that's not saying that other people within the healthcare team don't do that. We just focus on those things. This is another way of looking at patient care. So again, patient would be at the center of this. We end up being that manager of care. It jokes that oftentimes we clean up whatever the physician had told them, whatever the provider had told them. Providers are busy. They come in, they drop a lot of information on a patient. Do you have any questions? By the time they walk out, the patient has thought of 30 questions. Then never mind. As a nurse, you stay there. You have the time to sit at the bedside and answer these questions. Remembers within that nursing profession to work with each other, to care for that patient. And then we have all of these responsibilities kind of on the outskirts of that. Caring, ethical behaviors, teaching, learning, culture of safety. So we have responsibilities to teach you as graduates the qualities that you should have, and they're grounded right within our expected student outcomes. End of program outcomes. It will be in every single one of your syllabi. Demonstrate caring through advocacy for patients by recognizing the patient or designee as a source of control and a full partner in providing compassionate care based on respect for the patient's preferences, values, and needs. Collaborate effectively within nursing and interprofessional teams, fostering open communication, mutual respect, and shared decision-making to achieve safe, quality patient care in a variety of healthcare settings. Use nursing judgment based on best current evidence to ensure optimal outcomes for patients and families across the lifespan, and demonstrate professional identity, integrity, and leadership as a coordinator of patient care. And then Houston, we base a lot of our quality improvement on Houston concepts. And that's part of how we look at student-centered learning, just like we look at patient-centered care. We want to pull all of those in together. Are we teaching you teamwork and communication, quality and safety, professionalism? Each course should have elements of that, of each of these within your course, so that you are hitting on those every single time, and we're building on them, so that you get them with every class. All right, chapter 2, healthcare delivery systems. So we have 4 major challenges that are facing nursing right now. Our aging baby boomer generation. People are getting old fast. Lots of them. There is a shortage and uneven distribution of physicians, especially within rural and low populated areas. All those baby boomer nurses are starting to retire. And our healthcare system sucks. Just gonna put it out there. And that's being recorded, so don't tell Dr. Persons. No, she is. Yeah, our healthcare reform, it is in the toilet, right? Traditional levels of healthcare, and we will be reiterating this in every single class. We have preventative, we look at primary, secondary, tertiary, restorative, and then we look at continuing healthcare. And we will go over each of these. As we look at integrated healthcare delivery, primary and preventative healthcare services, our primary healthcare is exactly what you think it is. This is healthcare that is focused on improving outcomes for an entire population. But it requires collaboration. Unfortunately, the United States does not like to pay for preventative healthcare services. We're just barely getting on board with primary care preventative services being covered at 100% for a lot of things. That's only like the last 10 years. It's ridiculous. Because if you do preventative care, it makes other care way less expensive. Focused on reducing and risk factors for diseases. It's catching things before they go bad. It's just mind blowing to me that they don't think ahead. I don't want to pay a $50 doctor's appointment because it's expensive.
Okay, sorry, that was what I was, insurance companies are finally.
They're finally getting on board where they will pay 100% for preventative visits. Medicare and Medicaid drive insurance costs in the United States. If Medicare and Medicaid decide on something, then other insurance companies get on board. They decide they don't want to pay something, but other insurance companies are like, yes, we're not paying either.
Medicare, like.
Secondary and tertiary care, those are done by hospitals, intensive care, mental health facilities. Rural hospitals take up, they are caring for a lot of things out there. Anything comes to them, anything and everything. Then we look at discharge planning. Restorative care, this is your home care, rehab, extended care facilities. Then anything that's continuing care, this could be long-term care facilities, assisted living, respite care, adult care facilities, palliative and hospice all fall into continuing care. So when we look at issues, healthcare costs and quality. I'm gonna try really hard not to get on my soapbox. When we made patient satisfaction a score that we measured in healthcare, we did a disservice to patients and nursing staff, nursing population. Because we made healthcare even more of a financially driven business. I'll say it once, say it twice, I'll say it 1,000 times. Healthcare should never be financially motivated. It should never be for profit. Patient satisfaction, part of the reason why we have an opioid epidemic. Wanted to drive up patient satisfaction, give them medication, make them happy, make them leave. There's a direct correlation here. Lots of studies that show that. We also deal with the nursing shortage. Not necessarily in highly populated areas. There's lots of people who are graduating from colleges in California who cannot get jobs. California is saturated. New York is saturated. Guess who doesn't have nurses? Lamar, Colorado. Tiny little towns in the middle of Kansas, middle of Nebraska. You buy a house for $100,000 and get a nurse though. That's where we're seeing the nursing shortages. Everybody's flocking to these bigger areas. Competency. We are in the middle of switching from you, and this is being pushed out by the NCSBI, which is who creates guidelines for testing, like the NCLEX, of a competency-based model. Because not everybody tests super well on written exams. Awesome. I don't test well. I want to throw up. I shake horribly. Terrible test taking anxiety. Let me show you all the things I can do as a nurse. We're in the middle of changing that. Those are all things that will be pushed out by 2030, 2035. Great. Demonstrating competency is what I want out of a nurse who's taking care of me, right? Patient-centered care is not an issue, but it's something that we need to continue to be working on as we have greater respect for patients' values, preferences, and express needs. Very difficult to ask a patient, do you have any cultural needs? We're not allowed to ask about DEI. How do you coordinate and integrate care when you can't ask the question according to federal guidelines? How do you get out the correct information and education if you can't ask them if they can read or write English? I don't want to give a Spanish speaking only discharge instructions in English, because that's not going to work for them. And if I'm not allowed to ask, it doesn't benefit them. So there's advocacy issues that we have an obligation to be working towards fixing. Involving family and friends, their support structure is necessary for continuity and safe transition to home or wherever they're ending up going. And then access to care. We see this over and over and over again. Where you live, how much you make, do you have a car, do you have a job, do you have insurance, kind of insurance. Even the difference between Medicare, Medicaid, and TRICARE. Lots of TRICARE around here. Are you being seen on base? Or do you get to go off base? How long is it going to take for you to get in to see a specialist? My daughter, great insurance. There's horrible migraines. Took her a year and a half to get in to see a neurologist. What the heck? And that was between Pueblo, Colorado and Denver. That was the soonest. What the heck? Anybody heard of a magnet program or magnet hospital? Anybody had the opportunity to work in a magnet hospital? Did you notice the difference between a magnet hospital and one who was not magnet recognized? So magnet hospitals are specific to nurse-driven initiative, nurse-driven outcomes. They expect the nurses to be highly involved in how the patient's outcomes are recognized, delivered, and highlighted. Nurses are an active part of it. You have the opportunity to work at a magnet hospital, go for it. Technology in healthcare, telemedicine boomed with COVID. Love it. There's a time and a place. Robotics, amazing things are happening with robotics. Diversity, equity, inclusion. Yes, I'm saying the words, they're even being recorded. Yikes. We have a large amount of underserved populations. Our economic stability is worse than it has been in decades. Education directly correlates to the jobs that people get. That is not saying that our tradesmen do not make money. That is, I'm not saying you have to have a higher education in order to have good income. That's not what I'm saying. Statistically, the higher the education, the higher the income. The higher the income, the better the insurance. We see neighborhoods, entire neighborhoods being impacted. This is where we start to see just massive discrepancies in what people have available. When you look at health outcomes for healthy people 2030, and you see the social determinants of health, this is where we're seeing the problems. as nurses, you need to know the areas where you're living and the impact that has on your patients. So the future of healthcare. Guess what? It's always changing. They're in a constant state of change. Predictions show that it's going to continue to be consumer-centered, rather than say patient-centered as opposed to consumer, because it still indicates that it would be a business run as opposed to truly patient-centered. We're going to see an increase in telehealth and digital care. Office visits will decrease. I think that it's cheaper to do telehealth, but that means nobody's touching your patient. You're having telehealth visits, nobody's actually putting hands on them, nobody's listening to lung sounds, nobody's listening to heart sounds. So what is missed? They're fine for checkups, but my goodness, what's being missed? And then artificial intelligence will be increasingly used to assist in early detection, better understanding of disease progression. Think right now they're primarily being used for imaging and like comparison imaging from one study to the next, and guiding care and recommending different types of care based on imaging. So evolving healthcare plans. More and more expensive, less things are being covered. Healthcare services, we are wanting to see more health promotion and prevention, but still not at a place where we should be. Community health programs, we're getting funding cut left and right. There's not as good a coordination of care as we should have. So patient is even in spite of electronic health records. Patient sees their primary care and then they have a pulmonologist and a cardiologist and a nephrologist. Not everybody is talking. So they may have 5 or 6 different medications from 5 or 6 different doctors and they don't necessarily all work well together. And then how do we ensure that people are utilizing services appropriately and not kind of getting lost in the weeds when it comes to all the different options for healthcare? All right, population health. So when it comes to community-based healthcare, this is our model of healthcare that we look at. The very base of this is going to be population-based healthcare services. So what is going to serve the good of everybody in that community? It typically focuses on preventative primary care kind of thing. So what can we put out to the entire community that's going to benefit them? And that's where that clinical preventative services falls in. So think immunizations, think screening for STIs, that kind of thing for those bottom 2 tiers. Then we get into our primary healthcare, secondary healthcare, and tertiary healthcare. The goal of community-based services is to achieve healthy population and communities by really assessing what those healthcare needs are. So when we talk about populations, what do you think we're talking about, or a community? Could it be? Yes.
A little scale dependent, but this could be anywhere from like one community, so like a city, a town, a rural area, county, all the way up to like the entire United States.
Yeah, absolutely.
When you said STI, I think of college kids.
Yeah, absolutely. Or, a retirement facility in Florida. Highest growing population right now. They can't get pregnant. They're reckless. Over 65 and running them up. They do. They need sex education more than you guys do. Yeah, so it could be, so think about your populations as, it could be as small as the male population of the summer start of CSU Pueblo School of Nursing, which is 6 guys, right? 6, I count right? It could be that small to all of the male nurses in Colorado, right? So it depends on what your intentions are for your study, for your intervention, for who your population is going to be. A wonderful example that was put into place here in Pueblo was several years ago, the Pueblo Department of Health realized that the kiddos in Pueblo are more prone to obesity than others in Colorado. And they put out an incentive to local restaurants that they would receive additional funding, like a stipend, if they offered juice, milk, or bottled water as part of their kids' meal package instead of soda. And in order to do that, they got like an extra financial incentive if they promoted that as part of their goal for healthy kids for Pueblo County. This is still being done through Pueblo Public Health. And it's actually been being done over 5 years. And so now they're seeing some trends in kiddos with lower obesity rates. So something that was recognized was here's a problem, here's how we're going to intervene, and things that they're starting to see as their intervention has started to work. So it's neat to see that this was a widely identified problem, intervention, and then changes. So we use social determinants of health, looking at biological, socioeconomical, psychosocial, behavioral, and other social factors that all play in. So it doesn't necessarily need to be one singular thing that binds a group of people together. It could be other things. And then health disparities are preventable differences in a population's ability to achieve optimal health. So what things are causing that population to not have the ability to be healthy? What could we change to improve their health, their overall well-being? Public health particularly focuses on vulnerable populations, individuals living in poverty, so either at or below the poverty level. Children and older adults, they're always going to fall into that vulnerable population category. Those who are experiencing homelessness, racial or ethnic minorities, individuals who are being abused or have the potential for being abused, that generally is our children and older adults. People who are substance use abusers, and then those with severe mental illness. The responsibilities of a public health nurse, they are working on the health promotion of a population as opposed to individual people. Now that doesn't mean they aren't working with individual people. They're just focusing on what can I do to improve the health of that population, and then potentially doing those interventions. Screenings for early detection, and then disease prevention like immunizations, or even treatment of like STIs. They also do a lot of interventions. So when it comes to, they'll start with an assessment. What are they going to be doing? What are they looking at? What population are they looking at? They'll eventually start monitoring that health, diagnose, intervene, or investigate with that group. Work on, do they need to change the policy? Do they need to enforce the law? Do they have like maybe it's a water issue and they have to change how water is being delivered. And then they go through and they has that been fixed? Have they go and do an evaluation of what they've done? So lots of policy development is done within public health nursing and advocacy. All right, chapter 4, theoretical foundations of nursing practice. What is the theory that you guys can think of not nursing related? Sorry. String theory? Do you know string theory?
Not at all.
I don't either.
Gravity.
Gravity. Yeah, gravity. Gravity is not my friend. Usually end up on the ground. Horrible. What else? Evolution. All right. I like Newton's laws of motion. They are actually quite impactful in nursing, especially trauma. Objects in motion tends to stay in motion unless acted upon by an outside force. Guess what? Your organs stay in motion when you're in a car accident till they are impacted on your abdomen or, you know, right? So we have all these theories. We don't think about them every day, right? We don't like concentrate on string theory. We go, ooh, man, I gotta really get on that string theory and think about how it's gonna impact my Friday afternoon, right? That's not how nursing theory is either. However, we do use it. We use it a lot. And I do have to tell you guys, I'm pretty sure I didn't get one of my first jobs I applied for as a nurse educator because I told them the thing I hated the most in nursing was theory. I'm pretty sure I honestly, because they looked at me and were like, huh. Yeah, so like, so what, what do you, there's lots of questions. And I was like, yeah, I hate theory the most. And I look back on it now and go, that's really not a great answer. Because now as I've gone through more education and have really thought about it, we actually use theory far more than we ever recognize. And not even so much in the sense that you have to memorize all these theories. I want you to just understand them and then see how they end up interplaying in the care that you give your patient. So the very basis is theories help to design and implement nursing intervention. So the things that we do with our patients every day, theories are why we do them. So we don't just do things willy-nilly. We actually have a reason for them. It's the how and why behind them. It's not just yeah, I'm gonna go take a blood pressure every 15 minutes on a patient that came out of surgery. There's rationale behind why we do that. And it all stems from theories. It's concepts, definitions, assumptions that explain phenomena. Now, it doesn't matter whether it's nursing theory, string theory, gravity. It's how we put all of these very big concepts into something organized. On your PowerPoint, that's a link, the live link to open access website that has all the theories you could ever want to know in nursing theory. There are some that we're gonna go over in a minute that I want you guys to just kind of have at the front of your mind as you start to go through just this whole nursing school thought. It's taking scientific knowledge, things that we are learning about, and applying them to practice. The more research we do, the better our patient care becomes. The more evidence that we have behind what we do. Most of the time, a new theory comes about because we go, what if? Or how come? Why do we do? It's when we have that persistent question, that drive to want to know more, which is what is so beautiful about this idea. It drives that desire for knowledge. If we didn't have that, we would just be monkeys starting IVs and putting Foleys in. Instead, we have this desire for new and more knowledge to be gained, which sometimes turn into new theories or sometimes it's added on. So these are just basic. Brand is this big, broad, abstract, complex idea. Middle range are a little bit limited in scope, less abstract. A practice theory, which is where we live a lot of the time, it's narrow in scope and focus. It's very, this is what we do, this is why we do it. Descriptive, it describes a phenomenon, identifies circumstances in which it could occur. And then prescriptive is addressing nursing interventions. It guides a practice change. This is how we get nurse-driven initiatives that change patient outcomes. Like, how do we prevent catheter-associated urinary tract infections? Do nurse-driven initiatives like this one, right there. So some common ones. Well, there's Nightingale again. Our environmental theory. She said, guess what? A dirty environment is not good for your patients. Actually true, which is good, which is why it's still a grand theory. And guess what? Y'all should wash your hands. Thank you. Pepwau's interpersonal theory. We still use this to this day. Hildegard was onto something, man. She said, focus on the interpersonal relationships between nurses, patients, and patients' families. Wow, brilliant. She was into patient-centered care before it was even a catchphrase. Go for it, Nathan. That's Hildegard. I think she looks so regal. Oren's self-care deficit nursing theory, she scares me. I would not have wanted to be in her nursing courses. Dorothea. She focuses on the fact that patients, they oftentimes end up where they are because they can't take care of themselves. And we have to continually assess how much they're able to do. And our goal is to get them to be doing more and more on their own. Wow, that's a grand theory. Leininger's cultural care theory. This lady, way ahead of her time. She says, we cannot understand our patients and put them at the center of patient care unless we understand their cultural traditions, their values, their beliefs. Huh. It's in the 50s. What do you know? In her cultural care book in the 70s, she has like 4 whole pages on LGBTQIA. The first time it was published, they made her take it out. This ma'am, she was phenomenal. Middle range theory. Who knew? She was DEI before it was a thing. So, how do we know what nursing theories we should be working off of? Well, the reality is you're probably working off of all of them because somebody somewhere, some brilliant nurse somewhere said, this is a thing that we do. Here's the explanation as to why. So the State Council, the National Council of State Boards of Nursing, NCSBN, they came up with the clinical judgment model. They said, guess what, guys? You need to be able to make clinical judgments. We're going to model this with multiple layers, looking at the cognitive process and how you make clinical judgments. And then we're going to help you make safe clinical decisions. And that's one of the theories that the NCSBN has worked with to create that clinical judgment model. Now, within the paradigm of nursing, This is kind of combining all of those theories together. We also look at it from a holistic nursing position, where we have the patient at the center, looking at those lifestyle factors, the social community networks, all of the different things that impact that person, that patient in the middle, how that all plays into how we care for that patient. But also the nurse, what challenges is the nurse dealing with? Do they struggle with professionalism? Do they themselves have health challenges? What is the environment like that they're in? All of those things are kind of pushing down on the nurse and the patient. How does that help them get to their goal attainment, whatever that may be? Here's another example of holistic nursing. Patient, family in the middle with mind, body, and spirit. How is that all coming together for the best aspect and best care for that patient? All right, let's take 10 minutes. Back at 10 out. Yeah, so there's just two.
This one says.
Yeah.
That's not the one that helps centers. Romans, blah, blah, blah. It shows the order. It shows like.
Okay.
It's shown. Like, which one's that for you?
Do you need a drug? I guess that's just.
Here.
So.
So it's.
I'm not, yeah, so. Right now. Yeah.
How much you, that's just how much you. Yeah. Shoot, dude.
From the Pearson. Oh.
So I don't.
No, I. Like, yeah, I'm like, I started to be like, this is. It's not gonna be easy.
Okay, so.
Well, the one. Like first.
Okay.
Sorry.
This one is. Yeah, or you could write it down.
Yes, I have a house. You should have it.
Biggest goal. So one. Like, this is really hard. And the whole thing, past that, it's like a long, like. They're signed and everything. You can go for a long day.
Oh, yeah, not.
There's nipples.
Right.
Oh, it's a life.
Hey, when is it gonna have to back? Wait, is this the one that?
No, I see.
How do you get that?
Yes.
You have to do.
That's like an exact.
Yeah.
It's like this.
Which is like.
Bookstore, you can get this. It's like, it's like.
Yeah.
Yeah, walking this way, it's like. It's like straight.
Someone started. So they were there after 6, 5. Yeah. It's a like our. Yeah.
Have you tried the ghost ride? Or you have what? Yeah, I think probably that's good.
I like kind of like this.
You ever see? It's only the friends one though. For like the first. No. Have you guessed? I was like 124. What's that high for you? What number is that?
So like.
I did not think it was so hard. We can get adult seasons. It's like the team. Put your progress. Oh, yeah. It's right. So I got like all years. One that was just like upset. Like that would happen. Yeah, it's always that. You could also use just dollar. I could make.
You go and
See, like that's what's.
try adding, this,
But why would I use this?
What is it?
So the, I think.
this item. That's what I'm gonna say.
Plus it's 1,000 more. Stuff that we're doing right now.
So like you probably get your safe.
Well, like you, I got this one. My life. Yeah, we're already based on.
Oh. Oh,
And you know, like your concept now, because right now. Oh, it's, how you can get it. Coming out to milligrams, grams, or all these things.
Just a drug check, you know, it's like, issue.
Yeah, it's a good math problem for percentage.
Because he's too. You said you were a teacher?
Yes,
Oh, yeah, that's right.
Yeah, you might have to math teacher me. I'm not.
Yeah.
I think, yeah. Those are about it. It's math. So, let's get right.
I think.
She said she didn't let her at it, so I just texted Lynette, but Chris Cross, whatever this person. Yeah, it's quite.
One of them. This is Graham's right here.
And then we were pulling. Yeah, but it's fine and. There were two different companies. No, what I was trying to see is if you guys could add, they, so they have a new version of it.
So right here.
And so what I was seeing is if you guys could add the new ISBN file.
Yes.
Where it says up here, where it says.
You can also say.
This is where they had you put your new course under this item.
Oh, he's gonna get. But you know, like that, and you sneak it, then I get like lost. Or I'm multiplying.
So.
I did work in the house and I was on like.
Yeah.
It's not drawing. I was thinking staff. Our staff, that's all. And all that's really more.
All the else that's hard.
Like,
It's right, it's like, for tips, I didn't.
so like, what is that?
Lynette abilities.
Like, we went for.
So the next.
Yeah, she is.
It's probably a way.
I mean, no understanding. This is my.
No, like, so.
Evidence-based practice. Then B for evidence-based practice. So why do we like evidence-based practice? What does it mean when you hear those words? Somebody's done it before.
Give you confidence knowing that what you're doing will probably work.
I like that. Confidence in knowing what you're doing probably will work. Because humans they don't come with instruction manuals. Be nice if they did, right? So, yeah, we've done something that will guide us, right? That gives us that direction. So we have evidence that shows somewhere, sometime, there's been research that's been done. Says, yes, we've used this medication on this type of problem and it has worked, right? But we get evidence from other places. The patient tells us information. The patient says, I have high blood pressure, and here is the 15 readings from the past 10 days. Or I have a history of cancer, and here are the scans from 4 different doctors. Or I have really bad pain. My stomach hurts really bad. Don't push there. Please don't push there. And I have a fever. You take a temperature and you have that evidence, right? Then we have evidence from our own clinical expertise. Man, I have seen a patient, right-sided abdominal pain, won't let me touch them, and a fever. And because of what I know, what I've learned, that clinical expertise would lead me to be concerned for. Right, appendicitis. My first thought, I want to stay ahead of the ballgame on this one. What else could it be? All right, I make a list in my head. What other shenanigans could be afoot? And then I get other information that's going to add to my clinical decision making. Patient tells me about their preference. I learn about their values, things that are important to them. Patient tells me, I don't want blood products. I'm scared of narcotics. I'm a recovering addict. There are things that are very important. Please don't tell my family I have cancer. Those things become part of all the information that we gather, this one beautiful puzzle that becomes our evidence-based clinical decision making. And we're constantly adding to that puzzle that we know about the patient and what is happening with them. Now, sometimes that puzzle takes a long time to put together because, man, that patient is really complicated. Other times that information is like spilling out in front of you and you are just gathering up pieces as fast as you go because it is just, wow, I have so much information. But we have to have that. That's that scientific piece of gathering data. Now, we have to be accountable for what we are doing with that information and how we are caring for that patient. I hate the phrase, well, that's how we've always done it. And I am the first one. I don't know if that's going to work, but worth a try. Why not? Let's try it. Doesn't seem like it would harm it. Go for it. We've not done fundamentals on one day. I had to move pharmacology from when it used to be. Let's go opposite of pharmacology on the other day. Sure, why not? We can make that work. Let's try it. Go for it. Y'all are guinea pigs. If it doesn't work, let us know. Change it back next summer. Right? Because we can't know unless we try. How does that impact our quality? How does that impact the cost? We have technology. Patients, man. My labs are back and I haven't seen a doctor yet. What does it mean that my sodium is 135? Do you see how there's no codage associated with it? It means it's good. Happy with it. What does it mean that my white count is 14? It means you have a little bit of infection going on, right? How do we account for that when people are Dr. Googling everything? They want to be informed about their medical health. They also know if there could be an error. And using evidence-based practice helps us to be more effective, more timely, and then how to make appropriate clinical decisions. We should not just be out there like, yeah, I'm not gonna take a blood pressure, I don't feel like it. I don't think we need a blood pressure. Yeah, that guy looks great. I don't think he has a blood pressure. Or, no, he's pink. I bet his blood pressure's fine. That's not evidence-based practice, right? So making appropriate clinical decisions needs to be based on solid information. It is best practice. What we do at the bedside has to be grounded in best practice. Now, that doesn't mean we don't involve the patient in their patient-centered care, because that's when we're bringing in patient's choice, their values, their beliefs. How we bring those all in. We work on that problem-solving approach with the patient. And then we need to be mindful about where we find our evidence. Textbooks, journals, TikTok, you know. For you, man, TikTok is a wealth of information of what not to do. My favorite one in the past week. Anybody else has seen it? Somebody was nebulizing hydrogen peroxide. She had a little tickle in her throat. Thought she'd just nab some hydrogen peroxide and get rid of it. That is not evidence-based practice. In fact, it will kill you. We don't even put hydrogen peroxide on our wounds anymore because of how damaging it is to tissue. I cannot imagine what it does to the very precious alveoli that you have hanging out in the lungs. So yeah, that's one of my favorites. Internet resources. How do you make sure that what you're reading or what your patient is reading is appropriate? David's peer review. All right, excellent. .gov, .edu, right?
Oh, funding bias.
Ooh, funding bias. Yeah, when you Google something and the first thing that comes up is a pharmacy, like a drug route. Like, oh wait, I Googled a disorder and got the top, some pharmaceutical thing, like. How would I go further down the list to find when it's not? Policies, the policies that are in place at your facility, and then practice guidelines for wherever you're working as well. So evidence-based practice, when we look at research, we are wanting to have improved patient outcomes. Now, just because you went to some beautiful peer-reviewed website, you find this amazing article and you said, oh my gosh, we have to institute this right now. This is an amazing finding. This is going to make things so much better for our patients. That does not mean that that change happens overnight. Now, take for example, CODIs. So our catheter-associated urinary tract infection. We knew this was a problem. Nurses recognized this was a problem. Nurses said, we have to do something about it. But it took a lot of research and a lot of time before we came up with nurse-driven initiatives and the research behind it to say this has to be put into practice before we had the very best algorithm and the very best and most current information, accurate information, to have it put into place pretty much across the nation. I don't think there's a hospital, I'm not aware of one that's like, no, we don't do this, because we recognize how bad bodies are for the patient. So it's those kinds of things. Just because you may read this and say it's amazing and take it to take it to your provider, take it to the nurse manager and say, we need to do this, but fortunately, wheels of progress do not move very fast sometimes. That doesn't mean you shouldn't do it. Introduce it. Watch for new ideas that come. Because as new people, you have brilliant brains who don't get bogged down by the things you've always done it. So steps of evidence-based practice, how things happen, we ask clinical questions. We say, what, why? Can we do this different? And then we collect, how is this being impacted? What is that best evidence? Clinically appraise that evidence. Is this good evidence? Is this just anecdotal evidence? Is this something that, maybe this was a one-off? Or is this truly happening across patient care? Integrate evidence in with expertise and others that are along the same path as you. And patient preferences when making any kind of change in care. Evaluate what that practice change would look like and then share the outcomes of evidence-based practice change with others. Getting that information out is vital. If you change something in your facility and it is working and causing amazing outcome results, get that information out. Disseminate that information out by publishing it, by going to conferences, putting it out to the world, because sharing is caring. So I end all of my lectures with a food for thought. This kind of puts into your head what the next lecture will be about, something to think about. So what is the number one way to prevent hospital-acquired infections in your patients? And then we're done. Questions, comments, concerns? Obviously, 50 some odd slides is not enough. Gonna have to beef up my stuff for next week. Not next week after. What?
Oh. It's like a last.
The strawberries? Yeah. Oh, okay. Yeah. I know that it's gonna be. Speak outside. Great. Any other questions? Okay, I still, apparently the Lincoln passport is still not good. Let me see if Lynette. Mine worked.
Yeah.
So,
Got mine working.
yeah. Somebody worked. Oh, for the love. You know, the class code is in Blackboard.
The email that.
Yeah. So you have access.
Oh.
Never mind.
Yeah.
Because the class code that I gave you guys in Blackboard is for the new version. But if you got in and can see stuff, can you see that there's quizzes there?
We